So you can see how useful a walkthrough really can be, right? I mean, I still do them all the time, and I do them with my own organization. I do them after we change a policy or a process. It's a really useful tool to try to walk in the footsteps of a prospective customer. There's a couple of things over here that are just like truly amazing. The one about Googling with tobacco products. I mean, this is really symptomatic of the marketplace, right? I mean, what does the marketplace do? On the side of the market that's really about profit or capitalism, they're trying to make money, right? So anyone Googling trying to quit tobacco is using tobacco. So let us put an ad in there. You have to watch that stuff all the time when you're using social media, especially if you're the sponsor of the social media, right? And then the interesting thing where people are calling their influential friends, I mean, you're not the average consumer, right? And not for nothing, this thing transferred during COVID, which was, if any time has ever been a good time to quit smoking, COVID might have been it. So it transfers during COVID, and it hasn't come back yet. It's 2025. Right. So the point being made about the quality of the communication, you're all paying for these hotlines, right? There's government dollars at work paying for this kind of stuff that probably is not really encouraging people to navigate into treatment. I mean, the hotline that you use for PEP didn't work. You knew who to call, but that I don't. Right? So it's really baseline information that you can use to feed into a change process that's truly giving you some consumer perspective, right? So the advantage of a walkthrough is simply that. And all of these tools are intended to be used multiple times. And one thing I would say about hotlines and in particular is we like the idea. Everywhere in the world we have hotlines. Our friends in Lima, everybody in the room was in charge. The minister of health was there. They couldn't get a single person to answer nobody got an HIV test with every official number, like literally nobody, right? And it's very eye-opening. So these are good experiences to actually have for yourself. You're going to think differently now about patient care when it comes to PEP, for example, or about smoking cessation. And the other thing, and I'm struggling to write a paper about this, but I'm going to do it. The other thing is that a private market always develops if the public market is inadequate to the need, right? And the private market doesn't have, I'm not necessarily against private markets, but there are far less controls on private markets. And they really are almost always limited to people with resources, which from a public health point of view doesn't get you the kind of coverage that you want. So you can see the utility of a walkthrough. Thanks so much for doing that. I encourage you to do these things. Now let's talk a little bit about flow charting. And a flow chart is a kind of concept map, but it just like a walkthrough, it provides a starting point to understand the process as it currently exists, right? And even when we're talking about qualitative data, data is just data. There's no bad data. This is not bad or good, right? It just is. This is the state of things right now. And it gives you a platform to think about changing how things are going, right? I don't personally think that it's a great idea to encourage, to teach people about PEP and encourage them to call a phone number that nobody answers, because that's a hard phone call to make, right? And to have nobody, somebody made the point about training, to have nobody on the other end at all, or a person who's not particularly empathetic or trained on the other end is not that useful, right? If you're going to do something, you want to do it so that it results in the goal that you actually have, which is the person calling saying she needs PEP, should get PEP. Now she did, but because she was persistent and an educated consumer, right? Yeah, so flow charting is a starting point to understand the process, just like this is, It identifies key issues. You've pulled up some really key issues here. In a flow chart, it's a visual representation of what the experience that people have. And when you had the walkthrough right now, here's what you're doing. You're trying to figure out where to start, right? So this is a black box in most processes, especially in healthcare systems. We're often meeting people as they come in our door. But how did they get there? Did they make a phone call? Did their mother tell them? Right? How did they get there? And to the extent that we don't know the answer to that, we can't maintain any kind of quality, and we can't actually encourage more people to come. So if your strategy is hotlines, we talked about several different hotlines here, it's not working that well. Right? Again, just a fact. If that's your strategy, maybe you need a different strategy. Maybe you need to improve the hotlines. Maybe it's both. But you can learn that from doing a walkthrough. So right now, we could flowchart the process of seeking care for tobacco cessation, right? But we'd have to start at the person making a phone call. So the customer makes the phone call. Did someone answer the phone? Yes or no? These are changeable. If the answer is yes, did they help you? So we got a couple people who actually talked to a person who ultimately kind of helped them, but I didn't hear much satisfaction about being helped. I love the, yes, we have blood tests for that. Okay. Can I get the blood test? Like, how do I do that? Right. And then that's kind of an opportunity right there to add a little more information and to really encourage the person to come. Then when you did elicit that information, it turns out the burden's on you. You can only come on Thursday. And it costs money, right? Even though there's a public health initiative or a public health gain in you reporting that you're potentially exposed to TB, now the action step is on you. There are entire countries in the world that would flip that around entirely. Thank you so much for telling us, right? Here's what's going to happen. Someone's going to come and see you, and we're going to do a blood test, right? So there's a lot of ways of thinking. Maybe that's not a priority for this country, in which case that's potentially fine. But you've added wait time there, right? Today's Saturday. This is a person who worked up his nerve to call up and say, I think I've been exposed to TB. Have to drag the information out. This was also the case here in the mental health example. You had to drag the information out, and you have to pay for it, and you have to wait almost a week, right? So some real opportunities for just thinking about that. You can see those same kinds of opportunities in a flow chart, which is visual. On that top line there, that's the best case scenario. That's the best route that any person is going to have. Right? Yes, yes, yes. Most of the time what we see is, yeah, no, that one went to voicemail. Now there's nothing else here. Is anyone actually going to call me back? Right? You don't know. So people doing things that are, that they'd like to keep confidential, maybe like testing for HIV or requesting PEP, they're pretty reluctant to leave a voicemail. Hey, this is Lynn and my phone number is, that's not super confidential, right? So there are lots of ways of thinking about your goal, which if in the case of, wanting more people to use PEP, if that's your goal, you have to make the process easy enough, like my example of paying a bill where I'm going 1111 and the pills drop into my hand, or hey, we drop a pin and we'll tell you where the nearest vending machine is and you can go pick up PEP right now, because there's almost no reason not to do that, right? I mean, so there's lots of ways of thinking about, remember, we're focused on the aim. So you're using all of these tools to give you information that might move you in the direction of being more successful in that aim, right? What I would say is you don't have to be right. This is just data. And any idea that comes up that's testable, you should test it. But remember, we're doing rapid cycle testing, right? So if you want to find out how many people you could actually get on medication for tobacco cessation with this hotline. Just staff it for 2 weeks. Instead of going to voicemail, have someone answer the phone. Find out how many people are actually calling this telephone line. Find out what they actually want, right? That becomes really good baseline data. Right? You don't have to staff it from now till forever unless that is a useful solution. But also, don't publish something and call it a hotline and have no one answer the phone. Right? That's not a hotline. That's an information line. That's a different kind of frame right there, right? So flowcharting is a really useful way of thinking about process that's visual, but also includes the customer experience. When you do a flowchart, it's not a paper exercise, right? Really flowchart how this is happening today. Like my example, it might say, person goes into finance office. Yes or no? Well, what you don't know is that you never saw her again because she left, right? So you want to be really clear what's happening here. And the other thing I like to do is I often now I'm putting times here, right? The reception books the appointment. So she answered me, yes, that's happening in real time. Did she help me? Yes. But did she give me an appointment and how long did I have to wait? Or no, she didn't answer or they didn't answer. And then I never got a phone call back, right? So you can record time in a walkthrough and in a flow chart. Questions about either of those? So that's how you really get some good information about the potential patient experience, is using those tools. There are other tools. We talked a lot about nominal group technique. You can do that with prospective patients or actual patients as well. As Rick mentioned, if you just Google, if you just go into PubMed and put his name in or my name, David's name, you'll get some papers around nominal group technique. And you can see how we sampled or stratified samples of people using an intervention, people not using an intervention who we wish they would, people delivering an intervention, right? You can get a lot of information. And it's not a super lengthy process to do that. And then developing a SMART goal. So once you have all this information, right, what you want to do when you're working with a group, and we did this on Monday with the probationers. And so here's a group of people, 36 people, I think were there, 36 people in the room. And we asked them at the end of the day, so, what are you going to do now? Right? So they don't know anything about this, and now they do after sitting with us for 5 or 6 hours or 7 hours. And we're asking them immediately to set a goal, right? So a SMART goal is a single sentence that goes like this, right? It's a specific, measurable, attainable, relevant, and time-bound sentence. I want to improve the number of times the tobacco cessation hotline is answered by a person from 0 to 50% by the end of September. That's a SMART goal, right? That's not 100% of the way there. That doesn't tell you how that's going to happen. It just tells you what you're trying to do, right? But the reason for doing a SMART goal, remember, these people are social psychologists as well as engineers, that kind of thing. The reason to do this is to help synthesize learning. So you've been sitting somewhere, you're listening to a person like me or Irma. We're talking about, what we're going to do, why it's a good idea, Rick Ortiz. And then then you're going to go away and you're not going to have a coaching event for a month. So this is a way to bring together your ideas that are coming to the surface for you during that day after you've done a few of these things like nominal group technique or a walkthrough or both, and learned a little bit about the reason for trying to make the change that we're asking you to make. So SMART goal setting is a tool. It's a NIATEX tool. We have some excellent worksheets. We have another worksheet called the Quick Start Roadmap. that you can also use to get people started on a project. So what do engineers do? They try to break things down into manageable steps and processes, right? I wish more engineers actually wrote the directions that come with like that put together by yourself furniture that look like they're written by squirrels. You can't figure it out. I want to know, what is step one, what's step two, what's step three, right? That's what makes it most likely that you're actually going to move to action. So the breakthrough ideas in NIATEX from an implementation point of view, the key breakthrough idea is really aim setting. Issues are complicated. These public health issues that we're talking about that we really care about, that benefit us and the people around us, they're complicated. But they can be approached by evidence-based aim setting. You need to set a goal, right? Fixing the hotline is a goal all by itself, potentially leads to more people quitting smoking. But it's a step along the way, right? So you want as always, the change that you select to be related to the aim. So it's breakthrough, it's a breakthrough thought. Rapid cycle change. Do you want to make changes that are doable in 2 or 3 weeks or a month at the most? Like staffing your hotline for 2 weeks. There's no commitment there. It hasn't been staffed since COVID, apparently. And so it's not, if you staff it for 2 weeks, figure out what you learn, and you stop staffing it while you evaluate that, no one's going to die, right? But maybe you'll decide using that data from that rapid cycle change to move on with that, right? Implementation is guided. So that's what coaching or change leaders are all about. You're guiding the process. You're not actually telling people what to do. You're reminding them what to aim for. They're going to figure out the how of doing it, right? And you're going to be the guide. This works really well with parenting, by the way. Yeah, right? Implementation is guided with simple approaches that emphasize coaching and relationships. Teams actually build performance improvement capacity. So you saw Rick's slides earlier talking about Ukraine. I worked in Ukraine for 8 years, 9 years before the war started. And every single learning collaborative that we had, I led and guided those learning collaboratives. I was there. I wasn't doing very much by the end of the day, except reminding people to stay on the pathway. When we were not able to go any longer because the war started in February of 2022, we moved our coaching remotely. They've scaled up more since the war started, or more rapidly, I should say, than they had before. The curve went up again because they built capacity to work together, right? When we talked to them, how did you do this? Well, there's 25 oblasts in Ukraine. They created a WhatsApp group with all 25 of the chief narcologists in the same group. Like, hey, I have a patient in the East. Here's his dose of medication, and here's where he's going. Can you help me? Can you help the patient? I mean, they did that, right? They built their relationships with each other, and they built capacity to continue to change and grow toward the goal. Rick talked about Order 200 in 2016. Order 200 changed after we did nominal group technique. And the ways in which Order 200 shifted were exactly what the chief narcologists were recommending. That's a published paper, right? That's exactly what they found their voices to work together to advocate for some changes in the legal landscape instead of being separated by distance and by, competing priorities. They actually found a way to advocate. So there's a lot of utility in these tools that also builds, energy toward reaching a particular set of goals. The walkthrough is an opening experience. I really encourage you to think about walkthroughs and how you can take advantage of that. If you feel like you have the same sort of issues in your clinic or program, think about where the front doors really are And how does one really walk through one of those front doors? How do you do that? And then what kind of experience do you have? And then change needs to be tied to strategic advantage in real time. So again, I keep going back to this, to the presentation by David the other day when he talked about Hep C elimination. You know, everyone pretty much in the country understood at one point what the value was for that. That's huge advantage in this country stepping out and deciding that they're going to take up this issue of ending Hep C. The healthcare costs alone that are avoided there are just astronomical, right? For no other reason than that. That's just an enormous undertaking that has great advantage to the population as a whole and to individual people. So when you're thinking, these are breakthrough innovations of NIATEX. This is basically what we teach and we remind people of all the time. So to start a change project, you want to select a change team. We've done that in probation. That change team is going to have the 3 people on it that we talked about: a change leader, an executive sponsor, and a data person. Conduct walkthroughs. You can do them by phone. You can do them on your computer. Again, you know, we have to find a way of getting out ahead of the tobacco company. So that's a great learning from the walkthrough, right? Collect baseline data, use nominal group technique, use flow charting, use your own local information. How many people came in? How many people came back a second time? What was your no-show rate? You have data, but it may not be in a big system, but you have what we call cycle data, right? You can look at that. You can go backward in time for 2 weeks or a month and just do it by hand. Now, cycle data, because my colleagues are biostats people, and I love biostats, but the reality is if you're trying to make a small change in real time, you can't rely on that level data. You have to use your operational level data that you have before you, right? We do have a couple of good papers that show that cycle data is tied to long-term and larger change. And I can give you those references. And then you suggest a process change that might move toward the desired outcome. So we're asking, what's it really like to be a person in our care? What's it like to be the recipient or the customer of this intervention, whatever it is, right? Remember, understand and involve the customer from a factor analysis outweighs everything if you want successful change. It outweighs the other 4 added together, which you don't see that a lot in a factor analysis. What are you trying to accomplish? Stay focused on that aim. How will you know if a change is an improvement? You're asking a yes or no data question, right? Did the phone get answered by a live person more times in this 2 weeks than in the last 2 weeks? Yes or no? So are you moving in the right direction? Okay. What changes can you test that might result in an improvement? And then how can you sustain those gains that you do make? Right? So we have a few case examples, but before we do that, any questions? Okay, so one of the things we do as coaches and researchers in NIATEX is we teach ourselves and each other to recognize promising practices, right? What really works? And how will we pull that out? So if you have you have 6 change teams like we have in probation, and the next time we see them, they're each going to report on their work over the last 6 months. 2 or 3 places did the same thing and it worked. We'd call that a promising practice. And that might be something that we would then elevate to the level of spreading throughout a whole group of people, right? So promising practices, we're looking for promising practices. I'm going to show you a more complicated example so we can get to something else. This is from App Foundation. This is where I am at APT. Our aim, remember that big goal, was to reduce waiting time, which is a known barrier to treatment access, right? So what we know is that from the literature, and you can look at this, and I just looked at it again in December because I was writing a paper for something, and this hasn't changed at all. The number one reason people don't enter treatment for substance use is wait time. The number one reason you're not going to do TB contact testing is because you have to wait too long unless you call on Thursday morning. Right? So it's really hard for people to hang on to motivation, plus your life is complicated. So we took the evidence-based approach and we said, we're delivering treatment for opioid use disorder, medication, and we're trying to reduce waiting time, right? So methods that proven to increase access to treatment are informed by identifying and eliminating the barriers. That's what we've been talking about all week. Right? So if you want to implement something, you have to identify the barriers, and then you have to try to make changes that begin to eliminate those barriers. This is true across all healthcare services. So waiting time is a big issue for people. Retention is improved by shifting programs in ways that reduce program level demand. Right? If I have to come to you and I have to come on a certain day, as opposed to any time that I can come, that's a demand. How could you reduce that demand? You could make that testing available, 5 days a week or 6 days a week or at multiple locations or, so there's a lot of ways of thinking about demand. We saw in Rick's example earlier today that when we reduce take-home when we increase take-home dosing for people who were taking methadone, more of them stayed in treatment because it reduced the burden on the person. So healthcare systems create burden, right? You go to your primary care doctor when you can get in, you have to show up on the right day at the right time. They do your exam. You might have to go somewhere else to get a blood draw. You might have to go somewhere else to get a mammogram. That might be weeks or months from the primary care appointment, and so on and so on. And then we look at our markers and we say, okay, why don't people do these screening tests? Right? There's burden in making that. That's not a straight line. That would be a complicated flow chart. So there's opportunity there to think about how you might do that differently. Right? And as Rick said again earlier this week, all changes are not equal. Right? It's much more important to get somebody on a life-saving medication, for example, than it is for them to get a hearing test. Right? So all things are not equal. They're all important, but they're not equally important. So it's critical to keep that in mind. So we made a series of process changes over a 2-year period. We formed a change team. We did walkthroughs. I even involved members of the board of directors in this walkthrough. This was pretty risky. I was new in the job, but I thought, okay, let's get them to figure out like how this really works. We did nominal group technique with all staff. So I did nominal group technique with 250 staff across different locations, and I aggregated the data. Initial changes were sequencing admission process steps and task shifting. Those both turned out to be promising practices. So by sequencing, I'm talking about what do you do first, second, third, and what's the time between them, right? So if you could get somebody an HIV test, if they test positive and you could prescribe ART in real time, that would be a change in the sequencing of how it's mostly done across the world today, right? So what you do is you do two things. You short circuit the time by making it all real time, and you have literally gotten a person who's HIV positive onto a medication immediately that might lead to viral suppression, which leads to reduced infections. Right? So there's real value in thinking about sequencing. What's important here? And this is why I said, in another talk that I was giving, or it was earlier today, actually, that if you have 15% of your patient population who need more than just just the basic medication, for example, don't give the intervention to 100% of people because that just slows everything down. Prescribe the part that works for everyone and then figure out who needs those adjunct kinds of services like counseling or, psychotherapy or help finding a place to live. When you do that for everyone, you're making an assumption about the need that's dragging your system down. You can kind of start to undo that when you think about sequencing process steps so that you're figuring out who needs what along the way. And here's a couple tables, and I'll leave you with these slides, but some things we did back in the day. Admission occurred in this program only after results from a purified protein derivative or PPD test for tuberculosis were actually read. So we had to place the PPD at the time. This was like 2007 or something. We had to place the PPD. Then 2 or 3 days had to go by. We had to read the PPD. And we did all that after we met you, but before we gave you medicine. So I asked somebody, I said, well, what happens if they're positive for if the PPD test is positive, do you still give them the medicine? Yeah, sure we do. Okay, so how could we change that, right? Maybe you give them the medicine and they come back. 2 days later, you read the test, but now they've got the medication on board. So that's an example of sequencing steps. So we had it organized so that first you came and did an evaluation, then you had your PPD placed, not necessarily on the same day. Then you had a time we had to come back to have your PPD read. Then you had to have a physical, and then you could receive medicine. So about half of those people, after we met them, never showed up to get their medication, right? So we're spending resources on people who need the care, who aren't receiving the care, and are still in the community, right? Still needing the care for something that's actually a life-threatening illness, right? So another thing that we did that I think it was fascinating, people were required to pay any back financial balance that they had before they could re-enter treatment. So what do we know about the employment status of people who use drugs? Right? If they don't have money, they're still using drugs. So putting in front of them a barrier to treatment that's something like the last time you came, you left without paying, and so you can't come now until you pay, even though the medicine is what's going to help them get stable enough to potentially find a way to pay, is not very logical, right? So sequencing steps. So you just go through these are separate change projects, and every single time you plan the change, you do the plan, you study the results, and then you act on the new knowledge. You're not doing all these things at the same time, right? So we had long wait times, as I was talking about. People were assigned a counselor, and in order to assign them to a counselor, we did this thing called staffing, where we sat around in a room and said, oh, I think David would be the best person for this patient to see. Well, David's on vacation for the next 2 weeks. So the person doesn't have a counselor because David's not there, but he might actually be the best person for the person to see. But seeing another person is far better than seeing no one, right? So we moved away from this idea that we could understand like this perfect matching and all of that kind of thing, and just created a group counseling process. So we won't go through all of these, but here's what happened, right? Wait days to admission in June of 2006 when we were doing our walkthroughs, wait days from the point where we met you. So I don't even know how long they waited back here because no one tracked it. I don't know how long it was to their appointment. But after you had your first eval, from the time you took your first dose of medication, was 21 days. What do people who are using drugs do in 21 days without medicine? Yeah, they use drugs. And about half of them didn't come back because, they lose motivation, right? Or they feel unwelcome, or they're not getting their needs met. I mean, all of those things. So we started making that series of changes that are on the previous slides. And by June of 2007, we get this wait time to under 8 days. We were really pleased about that. But the magic number, honestly, is 72 hours. If you really want to you decrease your no-show rate, you got to get to 72 hours is the magic number. So here's where we started what we call walk-in access. So we re-engineered our front door. We doubled up our counselors on the front door. We stopped making appointments and we just said, come in any day until 11 a.m. We will see you today and we will get you medicine if you're a good candidate for medicine, right? So that results in about 2 days of waiting time. Then we figured out that we needed to pair up the counseling staff who were doing the diagnoses, these master's prepared licensed people, with the physician's staff so that the physical could actually be done and the order could be written. Right? So that gets us down to some people are getting medicine in real time. Now by here, you're actually at 1 day. And at this point, it's about 3 hours. So if you walked into App Foundation today, it's now 6 days a week, and you needed a medicine for an opioid use disorder, you would have that medication within 3 hours, and you would take it in front of us, and you might also see a psychiatrist, depending on if you're in that 15% category that we were talking about. So we've figured out a way it's not a perfect fit, but we've tried to figure out a way to identify people who are struggling more than others. So what I want to emphasize here is this is a long time, right? But this is not. So the system keeps getting better over time, but the bigger issue for us was reduction in wait time. That was what we were measuring, right? So are you moving in the right direction? Sure, at every point along the way. So what happens to census simultaneously? Here's what happens to census. It's the opposite curve, right? Literally, if you make it possible for people to do what you want them to do, they will do it. If you make it possible for people to get advice about smoking cessation, they'll get the advice. You'll have to figure out then if they navigate into treatment, but that's, it's one step at a time. Right? If you make it possible for people to do HIV testing, they'll get tested. There's no such thing as 100% solution. So we're not aiming for 100%. What we're aiming for is better than today, right? Better than today, over and over again. What you want to, right? How possible is it that something's going to go well today, right? Better than today. That's what you're looking for. So this is 100% NIATEX informed approach. It led to all kinds of things, including financial stability. I have a lot of outcome data here, but one of the things that people talked about was, well, if you let all these people in, how do you know if they're doing okay? So we began to use some baseline testing using some standard instruments for doing so, and that's what that other data is. And what we showed was fascinating, that if you let people in immediately, the people who endorse more symptoms of acuity come in at a higher rate. The people who are really sick that technically we're trying to get to the most urgently are the ones that are the most left out of systems that have a lot of complicated steps, right? So that's a public health conundrum. If the person using drugs who's also a man having sex with men is your target population for HIV testing, but it's impossible for that person to navigate to the current system, then your opportunity is to shift the system so it suits that individual's needs, right? And you can actually measure that. So what we were able to show is that what you can do is appeal to the high acuity population. So you saw from one of the presentations today that most people who present for ART in Georgia are already not doing very well. more than 50% of them. They're not in the viral load target range that we would like them to be to enter treatment, right? What's that going to do? It's going to make it harder to treat them. That means they're sicker, they're using more healthcare resources, they're more likely to die, they're more likely to have infected another person. Right? So when you think about that, that's an opportunity, that's a targeted opportunity. So the strategies that you're using now for HIV testing and navigating to ART, they just don't work for that group. That's all it says. Right? That's not bad or good, because you've got some really good data on the other side of that, right? But it means you need a different plan to get to that population, and you can figure out how to do that using this one step at a time approach, right? One step at a time approach. So as time to treatment declined, more people entered treatment. This happens everywhere in every healthcare service. If you feel overburdened by that, examine what you're actually doing, right? Because if you go into an emergency department, nobody spends an hour with you. It's very rare, right? What they do is they're sorting out how to save your life. That's what emergency medicine is about. So they've got it narrowed down, like, what are the most important things for me to have a look at right now? That doesn't mean all the other stuff isn't happening. It means I'm focused right now on the most important thing that I can do given the condition that you're in. That's a way of thinking about medicine at every level, right? It's really about task shifting. If our system is at capacity, but we're not moving on the public health side of that, we have to think about how we can shift the system. Right? It shouldn't take 8 months to get a primary care appointment. You shouldn't make a phone call while people aren't nice to you, where you're saying to them, I think I have a mental health problem, or I'm really worried about a family member, right? I mean, there's a lot of ways of thinking about shifting the system. The first question there shouldn't be about money. Is your family member safe? Hey, I'm sorry to hear that. Is your family member safe? Here's what to do if they're not. What do you do with that? You build a bond right away that makes it more likely that the person's going to come to you, even if there is some waiting time in there, right? So, and those who entered treatment were more acutely ill. What we also learned through our analyses, they gained as much improvement in the same amount of time as their less acutely ill peers. So at least when you're talking about issues like being unhoused or people using drugs or alcohol, a lot of what's happening for them, it appears to be symptoms of mental health issues or social violence, if you will, for lack of a better word, that go away or start to mitigate if they get on a medication. Not every person with a substance use disorder has a comorbid psychiatric disorder. It's just not true, although it might be true for some people, right? So you have to really just think about your system. And I can't emphasize enough that this was a one step at a time process that's an ongoing approach to treatment. So any questions there? Yeah, please.
I wonder if there is any cost associated to the changes, especially at the initial phase.
So one of the NIATEX rules is actually use existing resources. So we did not incur costs for the changes until our census got quite a bit higher, and then we started adding staff. But when we added staff, it was really offset by the revenue of more patients, right? Yeah. Other questions, anyone? So doing things in a different order, for example, you're still doing the same things, you're just not doing them in the same order. That didn't add any cost. Okay, people will engage in services. They'll they'll do your evidence-based uptake. This includes your staff, right? If we reduce the demands on the process, they'll stay in the treatment, they'll stay with the project, they'll stay working for you if it works for them. And it's easy to stay, right? So as you reduce demands, right, as you make metrics really transparent, as you include people in the change process, they're more likely to be invested in the work that you're doing. It's really important to use transparent metrics. So we publish these metrics everywhere. We put them on the lunchroom wall. Like last week, time to treatment was 11 days. This week, it's 6. Thanks, everyone. You know, I mean, it's not about having the right answer. It's about sharing the information. I actually have worked and coached in a couple of organizations where they post these metrics for the patients. Hey, we're trying to work on reducing waiting time. Here's how we're doing. Do you have an idea? Here's a QR code. Can you text us what your idea is? Right? That's an example of gathering some baseline data to really getting some feedback from the people who are involved. And building implementation change capacity leads to sustainability. So App Foundation was about a $12 million company when I joined them in 2006, and today it's a $42 million company, and we do exactly the same thing. We haven't added services. We've added locations, but we're still doing the same work, yeah. Fidelity in the metrics, the outcome metrics, or the process of using Niatex? The process of using Niatex. Niatex does have a fidelity measurement tool, yes. And it's available online. So you can see the Niatex website. It's right here, niatex.net. It is in English, but there's also a bunch of peer-reviewed publications attached there, which can, you know, maybe in your area of interest, there may be a paper out there because we've been doing this for a while now that can give you some good ideas. So the steps of creating a change project, you want to identify an executive sponsor and a change leader, conduct the walkthrough, pull together the change team, hold a kickoff meeting, flowchart your current process, identify change ideas. You can use nominal group technique or you can use flowcharting, assign roles and responsibilities, right? So, hey, we're going to have a person at the front desk. She's going to answer the phone. If she's on the phone and it rings, the person next to her is now going to answer the phone instead of letting it go to voicemail. So you want to be really explicit when you lay out the change, right? That's a pilot test. Develop a sustainability plan for any pilot test that works and celebrate and tell your story, right? So this is a roadmap for you to think about, right? Remember, PDSA, plan the change, do the plan, study the results, then act on the new knowledge. 2 to 4 week cycles, measure something that's a process measure. Answering the phone is a process measure. Writing a prescription is a process measure, right? Seeing how many people show up to appointments is a process measure. So focus on process measures because they are an approximation of movement toward your goal. So you're going to lead a change team now, you're going to establish direction that has a clear aim. You're going to create that sense of urgency. Why should anyone follow you to do this? Right? You really need to have some passion about this. You want to provide accountability and stay organized. Involve the right staff, as we've talked about. Communicate, communicate, communicate. Tell each other, what are you doing? Have regular meetings, even if they're 15 minutes long. They don't need to be long, right? Engage senior leaders. You want to tell the boss, like, hey, we've been working on reduced waiting time. And guess what? We've gone from 21 days waiting time to 14 days waiting time. And I just wanted you to know that. And my special thanks to the members of the change team. A single sentence or a text. You know, next time that person is talking to someone in the community who knows why the hotline doesn't work. Hey, we made this project and here's what's actually happened. People like to share success, but you have to help them know what it actually is. You want to motivate and inspire, commit to empowering your team members and your patients, right? Or the people trying to use the service. People getting testing in the community aren't technically patients, but they're consumers of the service that you're trying to promote, right? You want to create processes for short-term wins. Figuring out how to change one step is really different than looking at HCV elimination over a 2-year time period. You get some really good short-term wins in there, and they'll all add up to a good big picture over time. And then use the Niatex tools that we have available for you. When I say stay organized, I mean stay organized. Use coaching and Niatex tools. Record who attends the meeting, the date, the discussion highlights and ideas that come up, and most importantly, the plan that they make. You can literally do this in a little template this big. We have coaching worksheets, right? And 15 minutes. David was there, Echo was there, and Data was there. It was the 2nd of August, and what we talked about was the need to improve the tobacco hotline, and here's the 3 ideas that came up, and here's the one we selected. We're going to put it into play on August 11th, and we're going to meet again on September 1st. That's all, right? Really straightforward. This is not like open heart surgery. You're really making process changes here. And if you make this take 3 hours, it's going to be hard for people to commit to being a member of the team. But as a team leader, you stay organized. Make sure you have baseline data. Make sure you know what the group is doing. Make sure you set a date for the next meeting, right? I have a friend that calls it the exoskeleton. It's the exoskeleton of the work, right? That you're just hanging everything on this framework, basically, and the leader is responsible for this exoskeleton. Detours are projects not related to the goal. We talked about the waiting room. No feedback, asking people to make a change, but not telling them if it worked or not. Right? Not allowing them to have discussion. Insufficient leadership, like you ask people to make a change, but then you never show up again. Right? So don't be the change leader if that is the situation that you find yourself in from a work point of view. That's okay. Ask someone else to be the change leader. Support that person. Right? No strategic advantage. Like, why should I do this? Remember the principles of adult learning. People want to know the relevance. Why are you teaching me this? Why are you asking me to do this? Right? And then change cycles that are too big. If you are trying to change something and test it and it can't be evaluated in like 3 weeks or a month, then my advice is to shrink the change. Do something a little smaller. Right? So instead of evaluating how many prescriptions come from the hotline, which is an interesting and valid thing to try to do, but it's a much longer kind of project, evaluate how many times you answer the phone, how many calls came into the hotline, right? So shrink the change. They're all related to the overall goal. And don't forget, small changes really matter. For support, you can go to the website. You can email me, right? You can, all of those things. I'd really love it. And we talked about this a little last year. If some of you would undertake change projects, I would happily love to support you through that by email. For questions, you can email your colleagues, and I really encourage you to communicate. Here's a few peer-reviewed publications. There's one I'm going to highlight here in the time we have left together, which is about coaching. The second one is about integrated care, right? You have one here about e-health technology. So we've used Niatex in a whole bunch of settings. Here's integrated services. Again, this is a protocol paper. Here's one in AIDS patient care about real-world strategies to engage and retain racial/ethnic minority young men who have sex with men. in HIV prevention services. So we've used this approach in many different ways. Here is one about using nominal group technique in Ukraine. There's a NIATEX model for older adults. So again, if your particular area of interest is probably represented here. And if not, then you can be the one to write that paper one day. So I want to move on and spend just the last time that we have together on coaching and maybe one more exercise. But before I do, I want to make sure if there are any questions that we get to them. Okay, good. Thanks. Yep. Yes. Yes. Absolutely. Absolutely, yes. And so NIATEX itself is now listed on the evidence-based practice registry. NIATEX is an evidence-based practice, right? So when it's an implementation strategy, a set of strategies that has been, we did a randomized controlled trial. We've done all the things that you need to do to establish it as an evidence-based approach. So let's talk about coaching. Coaching is a challenge, right? Coaching is real work. We can't change the world the way the world is by opening ourselves to the world as it is. We may find that gentleness, decency, and bravery are available not only to us, but to all human beings. This comes from the work of Meg Wheatley, who's an organizational leadership trainer that I've worked with a lot of times. She's also the person who asked the question, who showed up as you today? When you're trying to do coaching, right? Who showed up as you today? Yeah, maybe if you're going to be change leaders, you're going to also be doing some coaching, right? Who showed up as you today? Am I willing and able to help with the learning of others, right? I mean, so part of coaching, again, is you're stepping into a space where you're facilitating and listening in a non-judgmental way, and then helping people synthesize all of what they're coming up with into actionable steps without telling them what to do, but guiding them in how to do that. So we're going to review the evidence for facilitation, talk about facilitation, explore approaches to that, and explore the importance of selecting facilitation tools that suit your implementation strategy. We've heard a bit about ERIC, the expert recommendations for implementing change, that was compiled and published in 2015. There are 73 discrete strategies. ERIC defines facilitation as a process of interactive problem solving and support that occurs in a context of a recognized need, right? Coaching is a common term we use in NIATEX coaching, a common term to describe the same process. Facilitation has been cited as the most important or among the most important tools for successful implementation. I can't stress this enough. You cannot just tell people something. You can't give a bunch of people a piece of paper and walk away, right? And say, follow these steps. So much education is about this. It's giving people a lot of evidence and saying, here's a protocol, good luck, right? What you need is a learning environment if you want success in terms of really scaling up an evidence-based approach. When you have a look at the literature, right? Implementation science, the key to successful implementation is facilitation. If you have facilitation, you see that intervention is effective 80% of the time in 3 years. If you don't have facilitation, now we're back to the no-do thing, but this is a different study. It's the same outcome. It takes 17 years and only 14% of the interventions scale up. So in terms of App Foundation, right, that example that we just looked at, in a 2-year period, the census tripled. So did we scale up the intervention? Yes or no? Sure we did. Right? That's with facilitation, really active facilitation. It's doable. Learning collaboratives. Which elements of a learning collaborative are most effective? This is a cluster randomized trial. We published this in 2013. I was a faculty member on this trial. I talked about it, 201 substance abuse treatment sites across 5 US states. In the conclusion, coaching and the combination of collaborative components were equally effective, but coaching is substantially more cost effective. Back to the question that came earlier, right? A 2019 systematic review of successful facilitation strategies included the following attributes: goal setting, assessing progress and outcomes, and providing tools and resources. These are the successful facilitation strategies in a systematic review from 2019. So now we've moved another decade forward in terms of really endorsing coaching as a very important component here. How does facilitation really work? We sometimes know that strategies work, but we don't really know how, right? So we took a look at that. We sometimes know that, and this is a 2023 paper, the Black Box of Coaching, the team that I'm a member of, we did qualitative interviews that were inductively coded from coaches that had wonderful results. And then we also had a look at 40 previously recorded telephone calls. And the analysis resulted in a 3-phase model of what happens when coaching for implementation. And the phases are this and these: building relationships. So today, we've talked a lot about how you can build relationships, right? By listening to people, by using these guided tools, by giving them the opportunity to actually have a conversation, by eliciting their input. If they're patients, you can build relationships. And then it's about building capacity, and then about building sustainability. So all around this is this circle where you have encouragement and positive reinforcing. Today's going to be a good day, right? You have that around this whole thing. Here you have the tools. This is how you build these relationships, right? Nominal group technique and flow charting and the walkthrough. And here you have change team, just regular change team meetings. So you're helping people build capacity. You're helping them figure out how to record what they're doing. And then you're going back and forth. Change teams, sometimes they have membership that changes. Sometimes you need to do nominal group technique again because you were pretty successful in your first change, but now you've got a new problem, right? Like the people we wish, we have a whole group of people that we didn't get the results to. So now what do we do? Okay. So you might have to start from the beginning. So there's a coaching model. Another team, about 2 months later, published a study looking at the black box of facilitation, and they used a modified Delphi consensus method to try to figure out how facilitation works in different contexts. So kind of a mechanistic approach, if you will. And 3 areas emerged: facilitator characteristics, organizational and human material resources, and contextual factors. These models are virtually identical, using 2 different approaches. So what we're saying, we think, is that building relationships really matters, that building capacity by employing these tools. So here you have in this one, building relationships, engage relevant leadership in target practice and environment, right? So you have the same kinds of ideas coming up in 2 different ways. So we're building relationships, we're building capacity, and we're building sustainability in a circle. Interestingly, this is a figure lifted straight out of this paper from Kilborn et al. It's also in a circle with all these swirly things that go back and forth. So what we're saying is that there is no linear model for coaching, that you actually have to help people along the way, and you have to be willing to re-inform what it is that you're actually doing. So other ERIC strategies that some people call coaching: audit and feedback, facilitating relay of clinical data to providers, et cetera. So when you go into ERIC, you can see that a number of things, and someone pointed out earlier this week that ERIC is getting kind of updated, right? We're pulling more of these ideas together, and the evidence is getting stronger for some than others. So you can have a look at the ERIC taxonomy, but it still remains the case that coaching is the most effective of the implementation strategies that we have. So there are a couple of facilitation techniques. So if you buy into the idea that it's important to be a good coach, to learn to coach, to use the tools, there are a couple of techniques, and motivational interviewing is one. This is an approach initially developed by William Miller and Steve Rolnick, designed to elicit behavior change by helping to recognize, explore, and resolve ambivalence. You can use this as a coach. This is not just a patient care tool. Right? These principles are excellent communication principles. Resist the writing reflex. In other words, don't tell people that they're wrong. Don't fix it, right? Listen. Let them listen to others. Create dialogue. Understand the person's own motivations. We've talked about this a bit. Why do, this is about building urgency. Why should I want to do this? Try and understand that. Listen with empathy. This actually literally came up in our walkthrough exercise, right? That the person was not empathetic. And then empower the person or the organization. So motivational interviewing principles are really embedded in the NIATEX model. But as a person, as an individual person, you're trying to learn to communicate in that way, or remind yourself to communicate in that way, even as you're using the tools that we have in the NIATEX universe. So you want to engage people, in other words, align with empathy. You want to focus them. What's the aim? You want to evoke why now. That's where your evidence comes in for your practice. And then how are we going to do this? This is the whole change process. So appreciative inquiry, and we'll pretty much end with this because we have just about enough time to do this. It's an asset-based approach to dialogue and engagement. Right? So appreciative inquiry builds on the idea that we can best improve systems by a focus on what is going well and a shared vision of a positive future instead of cataloging what's going wrong, right? A couple ways of practicing appreciative inquiry or positive framing. What is your nation? Yeah, that's awesome. We'll see. You can practice. Go ahead, Dada. You can practice asking positive questions. What's going well for you, right? You can find and share positive stories of when you or other people were at your best. And you can practice playing different roles and inspiring others. So there's an exercise here. We don't have really time to do this, but I urge you to think about doing it. It's really fun to do with people that you know, that you think you know, right? So you break into a dyad or pairs, ask your person what motivates you to do the work that you do. What's it really like to do your work? And what does a good day look like, right? It takes 2 or 3 minutes. Each person talks for 2 or 3 minutes. And then, well, you got to limit the time. Otherwise, we'll be here till tomorrow. And report back to the room or to your colleagues something that you learned about the person that you interviewed. Right? So this is an appreciative inquiry exercise that you can do with a change team, for example. We could do it now. We had a little bit more time. But in the interest of time, go ahead. Well, it's a really good question, right? So what motivates you to do your work? Yeah, right. And what's that really like? Right? This is a deliberately open-ended question. This is not to be answered necessarily in an objective way, right? What's it really like to do your work? Yeah. And what does a good day look like? Yeah. Yeah. Right. So what the effort here is to move people whose jobs and work often really lead them to being very objective all of the time, and that our relationships inside a team of people working together don't often include understanding what's driving the other people or what's driving a group of patients, for example. So appreciative inquiry is a really excellent technique. One of the things I like to do is just say, why? Why do you think it's like that? Right? So the phone doesn't get answered. Why do you think that's true? No, that's a sort of non-judgmental question that gets people thinking about, what the answer might actually be. So choosing facilitation tools and approaches, that remember that context is critical, and have a look at the consolidated framework for implementation, or the ERIC tool. So if you want to pick which exact coaching strategy might be best in a circumstance for you, you can use this tool. I guess I am advocating for having a look at the NIATEX coaching strategy and the references there on that slide. So any questions? We're going to end here. We have about 5 or 6 minutes together. Comments from people? Yeah. Dato. Yeah, here it is.
I have a question actually. It's not first time that I'm listening to your presentations focusing on NITEX, and it's really clear, understandable, and exciting. And you really, uh, I mean, and my perception is, yeah, of course, yes, this is how it should be done. So it's so clear, you know. And then when I'm starting to think about, and maybe, we need to apply all this next time when we will be working on implementing some innovation and so on. And then it's kind of scary. How, to what extent is it feasible to do for newcomer without having experienced fellow colleague who would lead this process, and then I will be, engaged and learning. So how is it possible for someone to just learn and go immediately and start doing it?
Yeah. So the answer is yes, it's possible. But we just talked for the last 10 minutes about coaching and facilitation. So it's more likely to be successful if you have the support of a coach. So we're colleagues. If you wanted to undertake a project, you have the opportunity. You can email me. We can talk on the phone. We can walk through that process together in terms of what, forming a change team, all of the things that we talked about. Now, if you don't have a relationship in that particular way, there is a video on the NIATEX website that can show you how to start. It's called PI 101, and it's in short segments. The tools are there on the website as well. But coaching is the most successful facilitation tool. I would say that. The second thing I would say, though, is that the tools, even if you don't do the whole package, form a change team and all of that sort of thing, the tools themselves, each of those discretely, you can successfully use them. You could successfully right now run a nominal group technique. You could sit with your team and draw a flow chart, right? You could do a walkthrough and you will learn some things from that. And then you can say to the people that you're working with, okay, here's what we learned. What do we want to do? So you're then doing a version of this, even though it's not existing inside a learning collaborative, you're still doing, you're getting baseline data, that's context, right?
Facilitation.
Yeah. Yeah. So facilitation, Rick wants to chime in here.
With the idea that everybody knows that you're an authority. If you have to tell everybody what to do, no, this is not right, you need to do it this way, turn everything into a no, or that's not quite right, into what do you think that means? And ask different kinds of questions so that you let them come to solutions. When people do monitoring and evaluation, the person who's doing the monitoring and evaluation looks at what you're doing and says, that's wrong, right? That's not coaching. That is just giving, well, it's not even just a control. I mean, it is one of the NIATEX, not my NIATEX. It is one of the sort of the categories in the ERIC taxonomy. It's usually having an expert opinion leader or something like that that's telling you what to do right. Coaching is not that, because it's really, you sort of say, oh, help me understand that. Why don't you draw that out in a flow chart so I can understand? So you're really asking for clarification as opposed to jumping to the conclusion. And that's a real trick to stop yourself from telling and switching from telling to asking. And I think that's maybe one of the things that.
Yes.
For last 10 years.
Yes.
Extensively. And I mean, I'm correcting my students, every day, every evening, no, sorry, you are wrong.
Well, and so you're also a physician, right? I mean, you have a lot of authority and it's been rewarded. That's what you do. You're a teacher, you're a physician, you know how to do things and you're imparting that knowledge. That is the biggest shift, right? So if you go back, and one of the reasons I use the motivational interviewing principles in this talk is, you want to resist the writing reflex. In other words, don't tell people that they're wrong. Don't tell them that their idea is bad. Listen with some kind of empathy. Let the group make the correction, right? So instead of saying, you need to tell us what this means, you might say, what does that term mean? I'm not exactly sure what you meant by that, right? It's just a different approach that gives the person the opportunity, or the group the opportunity, to enter into the conversation. Yep, right. Hasn't shut it down. All right, we might have time for one question, although I know it's been a super long week and day. Anyone else? He has one question.
So it's really interesting at what just Dr. David has mentioned. It's maybe sometimes a little bit difficult for the professionals to do this kind of coaching and facilitation, and because they don't have the experience, yes, so it's just something very new. Do you think this should be taught at the university level and on the public halls? It should be included in the curricula, so you are much better prepared?
I do think that facilitation skills are critical interpersonal skills. So yes, I think that, physicians, other caregivers, other social service people should be trained to have good interpersonal, right. I think the leadership course. So I think that's an interesting question that you're asking. Not for nothing, we have a lot of relationships in our lives, and they're not all about, getting our work done, but relationships that underpin the NIATEX ideas of mutuality, the co-production of knowledge, right? Learning together, respect and empathy. I mean, I think those are communication skills that serve all of us very well in all of our relationships. The struggle in NIATEX, I think, and Rick talked about it a little, Dato's asking this question, is that you really are experts in some things, right? But in order to improve the realm of influence that we have, we've just looked at all the evidence right up until the present day that suggests that coaching and facilitation is critical to successful implementation. So, here's the idea that you practice, you learn to be a coach. You're going to be a better coach a year from now than you are today. I have watched Rick learn to be a coach. Fascinating, really, because I was doing this before I met him. Well, some days.